What's up, guys? My name is John Hawes, RNCCRN with NRSNG.com, where our goal is to give you the tools and the confidence that you need to succeed in nursing school, on the NCLEX, and in your life as a nurse. To help you succeed on this journey, we've created weekly cheat sheets that we send to you every single Friday. To sign up, head over to nrsng.com/freebies. That's nrsng.com/freebies. And every single Friday, we'll send you a cheat sheet on pediatrics, OB, med-surg, mental health, ICU, critical care, every single aspect of nursing care to help you succeed. That's nrsng.com/freebies. All right, now let's roll into the show.
Hey guys, what's up? It's Susan with NRSNG, and I'm going to be talking about giving medications safely in urgent situations, which is a topic that I really enjoy because, it's part of the reason I became an ER nurse. I enjoy urgent situations. But I want to kind of talk about how the process goes for eventually learning how to give meds in urgent situations, and then how to prepare yourself for those situations and prepare yourself for those medications. So it all kind of starts off with the books, and I know that's not something you want to hear, but it does start by reading in a book and kind of getting bits and pieces, learning the names. And I know it's going to be super difficult. I found reading from a book horrendously difficult in the regards of remembering it, especially in an urgent situation. So yes, I have read about epinephrine, but this patient who is coding and everything is really intense right now, do I remember like all the details and the numbers that are floating around? Because I also have the numbers in my head for adenosine and amiodarone, and I have all of these numbers in my head right now, and what all makes sense. So there's the book reading, and then there's the experience that you get with it and how you start to really form your ideas and your It's almost like the file that you open up in your brain when it comes to that medication or even that situation and the certain medications that go along with it. So if you can memorize drugs, that's great. And even what you can memorize, if you aren't able to memorize all of it like I was, it's a great start. And it's most of the time, it's sufficient for administering like most of the drugs that you're going to be administering. But in urgent situations, it is the first thing I want to explain to you is that you should always get a double check. Never do that situation alone. Never just go head on, especially if you've never done it. Just start administering a drug that you have no idea how to administer, that you've never personally seen administered, that you haven't administered yourself, but you've read about it in a book, or maybe you've seen a YouTube video about it. So ask for help. But if there really truly is an urgent situation, you're going to have more than one person around you. So a group of people really come to help you out and support you. And there are multiple roles that need to happen in order for a patient to be safe in urgent situations, because it's not quick enough for the nurse to go to the Pyxis or whatever medication administration machine you guys have. So go to your area, get the medication, bring it over, draw it up, have all the pieces for drawing it up, including the blunt needle and the syringe and the flush and the alcohol wipe, and then also to administer it, and then to also write down everything that's happening and note the vitals and it's just impossible. So you have to have a team of people to do it, because all the things that I just described to you has to happen, but it has to happen now. And so you have a bunch of people and they all have their own roles, and it's almost, so depending on the situation in the ER, there are actually assigned roles for that. Like if you're running a code or if you're doing whatever. But it's really funny how I've noticed that when you are in an urgent situation, people gravitate towards certain roles. Nurses will notice, hey, we need to have a nurse who's getting syringes and drawing up the medications. I'm going to take that role. Or, hey, we really need someone who's going to to chart. I'll be that nurse. So you're going to have all these different nurses that come in and they kind of settle into their roles, or they already have pre-assigned roles if the situation is something that, in the ER we have certain things set up for it. So if you've never given a medication, if you've never been in that situation, it's unlikely that you are going to be participating in that right away. There's probably going to be other nurses that come in and kind of run that for you, or help you along the way. If, for whatever reason, giving this, you are put into that situation where you've never given that medication and you don't know about it, and you are one of the few nurses that are there and you have to do it, I highly recommend that you verbalize any concerns you have to the doctor, to the other nurses that are in the room. You question things. Hey, how fast should I be giving this med? Can I just double check my dosage? And you will hear people shout out, hey, by the way, I've got this medication going in at this time, and it's another double check. So you have all these ears listening, and they're hearing you say that out loud, and they're like, yep, that is the correct dosage, and that this is the time it's going in, and everybody will be a part of that. So you're going to probably observe for the first time, maybe even the first couple of times, depending. But then you will start to participate in the administration process. And again, like I said, you're not going to be alone, so you'll have multiple people to rely on. And eventually, you just kind of become more comfortable with it. And you start to learn these medications and the process, and see these patients like, you're like, holy smokes, this patient is crashing. I know I'm going to need the crash cart, and I'm going to need to call the charge nurse and the doctor into the room, and we're going to have to set up a team. And people come very quickly. So you'll start to recognize and be able to see urgent situations. And then having all of those people also, it just really helps you catch any sort of med error, gives you that checks and balances system. So how do you prepare to be in that situation in the first? I mean, I know that we go through the stages where we kind of observe, and then we participate, and then we become comfortable with it. But I actually have a cheat book, and it's a little notebook that so they're little note cards that I can pull in and out of a ringed binder. And I'd highly recommend you make this for yourself, for your drugs, for your hospital protocols, anything that you need to know that's specific to you, and also can be a generalized information as well, that really is a quick reference for you that you can carry around. Put it at your desk wherever you're charting, or put it in your pocket if you need to have it on the run. So you just kind of start off with a few drugs, and I have a list of drugs. I'm going to name them off to you that I think you should start your book with, but then add drugs to it as you go. If you find yourself in a situation and it was a drug that I didn't put on this list and you need to know about it, write that drug down, create a new page in your book, and just keep going with it and organize it in a way that makes sense to you. Maybe you learn something new and you don't have space on that card to write. Start over, rewrite your card out. Always going over your medications is a good thing. So the list that I have, I'm just going to go through the base list that I think that everybody should have in their book. And I may be missing some, but I'm pretty sure this is kind of the base. So epinephrine, amiodarone, Cardizem, Heparin, Nitroglycerin, Adenosine, Levofed, Propofol, Dobutamine, dopamine, fentanyl, Versed, Rocuronium, and I never can pronounce this one right, succinylcholine, but we call it Sux, and it's a paralytic. And then lastly, TPA. So what you would give, it's a clot buster you would give for someone having a stroke. And I'm gonna kind of, that's the kind of the list that I really believe that you guys should start with. Read through, pages or information about it, maybe watch a couple YouTube videos about it and write down the things that you think are important, and you may end up getting experience with that drug and be like, why would I write that down? Or that's not pertinent to what I need to know, and you cross that out and start your card over again. But giving yourself a little bit of a base reference is something that I highly recommend. And if you don't give these drugs, let's say you work on a med-surg floor and you're not allowed to give some of the drugs that I gave. I know a lot of nurses are like, oh, we can't push levofed on this floor. Or if there's a code that's happening, they have to call a code team, and the team comes and runs the code, and they don't actually do that. So what do I have to say about the drugs that I just gave you a list for? I say start with those drugs anyway. And the reason why is because you may be caring for that patient post them having any of these drugs, while they're having any of these drugs. And it is very important for you to know what it is that can happen to your patient. What do you need to monitor for? What is, is there a cardiac rhythm that you need to be looking at? Vital sign that could, potentially be an alarming thing while they've had this medication. When do you need to notify the doctor? Things like that. And of course, for your own sake, like you can write when you're adding your own drugs, if they are drugs that you're giving, or even if they're not, you want to write indications, contraindications, if that's pertinent to you, how to administer it. Do I give this med fast? Do I give it slow? Is it mixed with something? What can I mix it with? Things like that. Any interactions you need to be worried about, allergies to medications, labs that you need to watch, and then of course side effects. So those kinds of things are really important. And I'm just going to read off a few things that I wrote down for some of the drugs that I listed off there. For the first couple, I wrote some of the stuff, I pulled it right out of my very own book. So epinephrine, you want to remember there's two ways to give it. IV is for cardiac arrest. You do not give epinephrine or EpiPen, where like people think about epi, they think EpiPen. For an allergic reaction, you do not give that IV. You give it IV for cardiac arrest. And when you are giving a patient epinephrine IV, it will be 1 in 10,000. That's the concentration. Now, you should, in your, I call it a Pyxis. I've worked at places it's called an Omnicell, but there's like different ways that you can go get your meds. So wherever it is that you're getting your meds, both concentrations, both 1 in 1,000 and 1 in 10,000, those are both going to be in your Pyxis, and you need to know the difference, and you need to know why you would give one versus the other. So if you're giving it for an allergic reaction, you're going to be giving it intramuscularly, like an EpiPen, and that is 1 in 1,000. Now, how do I remember that? I wrote a little note on my note card because I had someone mention it to me. If somebody is having a cardiac arrest, you are going to have lots of people running. So 10,000 people running into that cardiac arrest. But if somebody is having an allergic reaction, and I know that if you're having anaphylactic reaction, more people are going to be coming to it. But a cardiac arrest is a cardiac arrest is a cardiac arrest. An allergic reaction can vary. So if someone comes in and they were like, yeah, I had some tape on my hand and I'm having a little bit of a rash now. I'm having an allergic reaction to that tape. Nobody is really going to come running. You're going to have fewer people caring for that patient than you would have for a cardiac arrest. So that's the 1 in 1,000 concentration, and that goes intramuscularly. And I also remember that cardiac arrest has to do with your veins and your heart. So in order to get inside of the veins and inside of your heart, you have to go intravenously. So that helps. So these are the kinds of things that I write in my book. Little tips and tricks for like, what do I need to know about epinephrine in a pinch? What do I need to know immediately? For amiodarone, I mean, there's a lot of things that you can write, but one of the things that I had a patient who got amiodarone and they were allergic to iodine. It's contraindicated in patients that are getting iodine. And I learned that. So now that's one thing that I know very well, but I also wrote it down under my amiodarone card. Do not give it to patients that have an allergy to iodine, or it's contraindicated. For Cardizem, I wrote, it's a calcium channel blocker. And statins, calcium channel blockers, ACE inhibitors, all of those medications I found super confusing because they kind of sort of did the same thing, but in different ways. And in medications like that, I tend to write out how is the mechanism working, or the pharmacokinetics, or however it's pronounced. So I did write calcium channel blocker, and then in parentheses, inhibits cardiac muscle and smooth vascular muscle contraction. But this means that it's going to slow your heart rate and lower your blood pressure. So Cardizem, lowering BP, lowering your heart rate, or slowing your heart rate. For heparin, I wrote to make sure you get your coagulation studies drawn before you start that, because you need to have a baseline. The heparin is going to be constantly monitoring your PT, your PTTs, your INRs. So you need to know what the baseline is, and then in 6 hours, you'll get it drawn again and adjust that heparin drip appropriately. And if it's not a heparin drip, I wrote, to make sure to alternate spots. I don't use that in the ER, but it was something that somebody said to me, and I wrote it down once, and I don't have a lot on my heparin card. So to alternate, left abdomen to right abdomen to left arm to right arm, kind of a thing. Nitroglycerin drip, I wrote that I need to know the max dose that I should give a patient is 200 micrograms per minute. And I mean, it's rare that you're going to max out on a nitroglycerin drip, but it's good to know that that's the point where you're like, whoa, I've titrated too much. I need to not go this high, or we need to look into something different. I need to talk to the doctor. Because every time you titrate a drug, which nitroglycerin is titratable, you're not going to alarm the physician. By the way, I titrated this drug up or down. It's a set reason why you would titrate it up or titrate it down. So that just kind of gives you a parameter. Like, even if you're getting close, like if I'm getting super close to the 200, I might mention it before I hit that 200 micrograms per minute. And then the last one I'm going to talk about, I have written down adenosine. And this is one of my favorite ones because there's a couple parts to it, but it hits on one thing that I found interesting. I know that a lot of people focus on contraindications and dosages and things that you need to monitor for, but this one, I hit on the fact that you need to know the indication for this medication. It is something that you're going to be giving in an urgent situation, and the person's going to be coming in supraventricular tachycardia, or SVT. And so their heart rate is going to be super fast. And it's going to be one of those situations where you're going to give that med, you're going to push it super fast because it has a half-life of 10 seconds or less than 10 seconds. So it's like a bang, bang, bang. You give it, you draw it, you give it. It's 6 milligrams, 12 milligrams, 12 milligrams. 6 milligrams, if it doesn't work, you move to 12. And then if that doesn't work, you move to 12 again. And there is research out there that can state, if you are giving 6 milligrams and it doesn't work, 12 milligrams isn't going to work. I've actually seen it convert after giving 12 milligrams. So it just depends on the doctor and what they're going to call out. But the reason why I pointed out the indication is because if you have a patient that is in, let's say, AFib, which is another heart arrhythmia, adenosine isn't going to help it. That is not something that you give adenosine for. So it's only for SVT. And so I wrote that down, only for SVT. And now, like, when a patient comes in with SVT, is that what I'm thinking? Do I need to stop and look at my book? No, but the fact that I wrote it down, the fact that I have that written on there, it really helped me to remember. And then in regards to the 10 seconds of half-life, I mean, the reason why that's super important is because you are pushing that medication and you are pushing it super fast with a flush behind it that is extremely fast, because if it doesn't reach your heart, it's not going to do anything for your heart. It'll convert before it reaches your heart, and then that's the end of it. So these are just some ideas on how to write out different things for your drugs. And then, of course, the list that I provided is kind of where I would start, and then add things as you go. Not even just new drugs, but new information. If you find yourself in a situation with heparin, let's say a patient gets their INR comes back too high, and you're like, whoa, the doctor was concerned about this, and they said that, according to our heparin nomogram, we aren't supposed to be giving heparin anymore. We titrate it down, or however it is. Maybe you want to write that note, whatever that hospital protocol is, INR greater than 2 or whatever it happens to be. So, again, I hope this really helps you guys give your medications safely in urgent situations, knowing that you are going to be surrounded by a team of people. You aren't going to be thrown into that situation by yourself, and you will have gone through a process of watching it, then doing it with the team, and then you eventually become comfortable with it. And then also with the list that I gave you, a place to start, and if you have any more to add it on. So good luck, you guys.
All right. I hope that was helpful today, guys. I hope that gave you some motivation, some inspiration to go out and to be your best self, to go out and to become the nurse that you want to be, to make a difference, and to do the best work that you can. Listen, we're here to help you along your way. At NRSNG.com, our goal is to give you tools and competence to help you in nursing school, on the NCLEX, and in life. One of those tools we created is our Friday freebies, these weekly PDF cheat sheets that you can refer to on the clinical floor, in the classroom, and just throughout your entire career as a nurse. To get these cheat sheets, head over to nrsng.com/freebies. That's nrsng.com/freebies. You guys, if you need anything, we're here for you. You can reach out to us on social media or via email at contact@nrsng.com. We want you to succeed. We want to help you along the way. We're here to hold your hand. We're here to give you the tools, the confidence that you need to achieve success in this journey to nurse. All right, so you guys know what time it is now. It's time to go out and be your best self today. Happy nursing.